Good afternoon, everybody. Welcome to the December edition of Visiting Professor, named in honor of Dr. Sharma's father, Ananda Sharma Visiting Professorship. Welcome and happy holidays to all. We actually have a very special holiday treat. The conference today is sort of going to be unique and distinct. And we are extraordinarily privileged to have one of the absolute legends in cardiology, cardiothoracic surgery, meet one of the legends in cardiology, our own Dr. Fuster, for this conference. Dr. Schaff has been here before. It's an extraordinary honor when he graces us with his presence, not only because he is world-renowned, a pioneer in the field, has impacted so many of the different aspects of cardiothoracic surgery that are practiced around the world today. But I can say without a contradiction that he's truly a thinking man surgeon. And dealing with the surgeons here, that's not an oxymoron. I think that we're privileged to have many surgeons who are thinking men, and we're privileged to interact with them on a regular basis. We should highlight and acknowledge that this month there were two fantastic educational conferences put on by our faculty here at Mount Sinai. Dr. Fuster's consultant course in cardiology held annually in December, in which there were over 2,500 people from around the world. Dr. Sharma's course, which piggybacks with that in the Valve Summit, had an extraordinary audience, both live as well as online. These are programs which, again, are sought after online, and they can be reached as well online. Our programs are on CC Live Cases, and I'm just going to ask the speakers to remember to speak loudly into the microphones so that they can be recorded. I just want to mention briefly the faculty who will be on the panel, and we're very privileged. We have our thinking man surgeon, one of our many, Dr. Stelzer, who actually is delaying an operation that he's about to go into to be on this panel. We appreciate that. Dr. Croft, who's Associate Professor of Medicine and Cardiology, Director of the Echo Lab. Dr. Anna Purakini, who is Director of the Cardiac Catheterization Lab, an innovator in her own right, the Zena and Michael Wiener Professor of Medicine. Amy Kontorovic, who is the Director of the Adult Congenital Heart Disease Clinic. Dr. Donna Mancini, Professor of Medicine and Heart Failure. Dr. Meller, one of our mentors to all of us, Professor of Medicine and Cardiology. And certainly, last but not least, is Dr. Lampert, who is going to give us an overview. And the panel is going to be moderated by our legend in cardiology, Dr. Valentin Fuster. Josh?
Hello, everyone, and thank you to Dr. Schaff for being with us this evening. Thank you as well to Dr. Fuster, Dr. Sharma, Dr. Goldman, and our panel for making this evening possible and for what I'm sure will be productive discussion. Hypertrophic cardiomyopathy, or HCM, is a global disease with a prevalence of approximately 1 in 500. Since its description in the literature over 5 decades ago, our understanding of this complex and heterogeneous disease is actively evolving. HCM is characterized by left ventricular hypertrophy associated with non-dilated ventricular chambers in the absence of other cardiac or systemic diseases capable of producing the observed degree of hypertrophy. There are challenges in diagnosis and distinguishing HCM from clinical phenocopies, such as infiltrative or metabolic diseases, which may likewise demonstrate ventricular hypertrophy on initial echocardiographic evaluation. Furthermore, the pathophysiology is not limited to just ventricular hypertrophy, but also includes medial hypertrophy of intramural arterioles and reduction of coronary flow to myocardium, already at increased oxygen demand from hypertrophy and adverse loading conditions. HCM is an autosomal dominant disease with over 1,400 identified mutations in at least 11 genes encoding sarcomeric proteins. There is variable penetrance And patients who test positive for a gene mutation but have a structurally normal heart, the so-called genotype positive, phenotype negative patients, are still at significantly elevated lifetime risk for developing clinical or phenotypic evidence of disease. Most affected individuals with HCM have a normal life expectancy, without disability or need for major intervention. However, in some patients, the disease progresses, resulting in heart failure, atrial fibrillation, stroke, or sudden cardiac death. The overall incidence of HCM mortality is 1% per year. And yet, patients reaching the 7th decade of life have a risk of sudden cardiac death of about 0.2% per year, comparable to the general population and highlighting the role age may play in management decisions. This brings us to our first challenge, risk stratification. The 2011 ACC-AHA guidelines highlight established risk factors to be considered in assessing which patients are in danger of ventricular arrhythmias. Risk factors include a personal history of ventricular fibrillation, sustained VT or sudden cardiac death events, a family history of sudden cardiac death, unexplained syncope, and maximal LV wall thickness of 30 millimeters or more. Other risk modifiers with less data to prompt immediate intervention in the absence of other risk factors include non-sustained VT and an abnormal blood pressure response to exercise. While previously considered a risk modifier, new data have demonstrated late gadolinium enhancement on cardiac MRI encompassing 15% or more of LV mass, doubling risk of sudden cardiac death. Likewise, the presence of an apical aneurysm, present in about 2% of apical hypertrophs, carries a 4.7% risk per year of ventricular arrhythmias and 1.1% risk of thromboembolism. Our understanding on how to best risk stratify patients continues to change, with an enhanced ACC-AHA risk stratification model, including late gadolinium enhancement and apical aneurysm, having been recently compared to a European Society of Cardiology risk calculator. While the ACC-AHA method was less specific, it was 87 to 95% sensitive for the prediction of sudden cardiac death compared to the ESC calculator, which was only about 34% sensitive at identifying patients at risk. More recently, data has come out questioning whether we have been overestimating the risk of sudden cardiac death in the general HCM population. Previous estimates suggest the rate of sudden cardiac death is 1% per year. However, data out of an Ontario database suggests the incidence may be an order of magnitude lower than what we previously thought. According to data from an international multicenter registry of HCM patients who have undergone ICD placement, the rate of appropriate ICD discharge was 10% per year in patients who underwent ICD placement for secondary prevention. However, this was compared to 4% per year in patients who underwent primary prevention ICD placement. While an entire course could be dedicated just to the discussion of risk stratification, we are here this evening to consider advanced therapies. The options for advanced therapies primarily focus on the relief of symptoms. Patients are considered to have obstructive disease when the left ventricular outflow tract gradient is 30 millimeters of mercury or more, and invasive strategies are generally considered only if the gradient is at least 50, either resting or with physiologic provocation, as it is unlikely that a lesser gradient alone should invoke blame for clinical symptoms. Options for advanced therapies for HCM include surgical septal myectomy, alcohol septal ablation, and for apical hypertrophs, apical myectomy. In so-called burnt out or treatment refractory hypertrophic cardiomyopathy, heart transplantation is an option that can afford increased longevity and symptom improvement. An important consideration to take in context is potential mitral valve and subvalvular apparatus pathology. The mitral valve is an important component to treatment planning, as in some patients, it can be addressed at the time of myectomy or result in a different treatment strategy. Pursuing intervention at an experienced center is of paramount importance. For septal myectomy, the operative mortality with experienced surgeons is approximately 0.4%. However, operative death has increased 12-fold if performed in a center with less experience and lower case volume. Septal myectomy permanently reverses symptoms with about 70% of patients achieving complete symptomatic resolution and appreciates technical success in 90 to 95% of patients. Furthermore, the literature suggests that septal myectomy may reduce the risk of sudden cardiac death as it is associated with equivalent long-term survival compared to the general population. Alcohol septal ablation involves the injection of ethanol into the septal perforator, resulting in a localized infarct with subsequent remodeling and septal thinning, thereby enlarging the LVOT. It has advantages over septal myectomy, including being less invasive and requiring a shorter hospital stay. Alcohol septal ablation has a peri-procedural mortality of about 1 to 4% and is associated with an increased risk of high-grade AV block. This may occur in 10 to 20% of patients, a physiologic consequence of targeted septal infarction, which is considerable in the context of the 2% risk of high-grade AV block in patients undergoing septal myectomy. The risk of complete heart block in patients undergoing septal myectomy who have previously undergone alcohol septal ablation can be as high as 85%. An important aside is to not trivialize the 5% in-hospital and per-year risk of ventricular arrhythmias in patients who have undergone alcohol septal ablation. There appears to be an increase in repeat septal reduction intervention after septal ablation at a rate of approximately 11 to 35% compared to 1.5% with septal myectomy. This must also be taken into consideration in the context of the aforementioned risk to the conduction system and the implications of implanted devices, particularly in how we may opt to approach older versus younger patients. Invasive strategies to augment treatment options include heart transplantation in refractory cases and apical myectomy in those with apical hypertrophy, which seems to compare favorably compared to transplant as far as long-term survival. The future approach to the management of these patients likely includes further enhancement of risk stratification models, with a potential role for advanced imaging, strain analysis, and artificial intelligence. Likewise, advancements in understanding of genetic considerations may have a role as our understanding of this complex disease improves. More novel pharmacotherapy is currently under investigation, such as in the Pioneer open-label extension trial, of which preliminary data of the study of drug mavacamten, an orally administered small molecule modulator of cardiac myosin, appears to show some promise in the reduction of LVOT gradients as well as improvements in symptoms and dyspnea scores. However, high plasma concentrations appear to be correlated with an expected reduction in left ventricular ejection fraction, as well as atrial fibrillation. Thank you for your attention, and I look forward to hearing the insight of our expert panel.
Good, Josh. Good job on a complex subject. Let me start by introducing the visiting professor today. I remember when I was part of the search committee at the Mayo Clinic, and this was about 1980, that in fact Herschel was recruited from Johns Hopkins. I still remember this very vividly. So time moves on. Herschel was born in Holden'sville, Oklahoma, and he actually was educated in terms of obtaining the medical degree at the University of Oklahoma. He then moved to Johns Hopkins, where he had a number of jobs there: internship surgery, resident surgery, research fellowship, cardiovascular surgical research laboratory, senior resident surgery, and finally he made it as resident cardiac and thoracic surgery. This was in about 1980. So then he moved to the Mayo Clinic, where he began to assistant professor, then associate professor, and then the Stuart Harrington Professor of Surgery in 1992. And in 2001 to 2011, he was the chair of the Division of Cardiovascular Surgery at the Mayo Clinic. Well, he had a number of awards from the very beginning. First from the University of Oklahoma, the Moorman Award for outstanding performance. MD Graduate with Distinction, George Swedeman Resident Research Award at Johns Hopkins, Teacher of the Year, Department of Surgery at Mayo Clinic, Individual Award of Excellence, Mayo Medical Center and Mayo Clinic, and Teacher of the Year in Surgery, and I can go on and on with all these awards. He had important positions in most of the societies. I want to emphasize that he was president of the American Association for Thoracic Surgery very recently. And then he had important jobs in the American College of Cardiology, American Heart Association, as chair of the Council on Cardiovascular Surgery and Anesthesia, for example, and in all the cardiothoracic surgical groups. I like to emphasize that he has been very, as an editor, he has participated in many journals, actually as associate editor or a member of the editorial board in 12 journals. He's associate editor of the Journal of Thoracic and Cardiovascular Surgery, and then he participated as editor of the Mayo Clinic Practice of Cardiology, 3rd edition. I must say that I think Dr. Brandenburg, Giuliani, and myself worked in the 1st edition of the book of the Mayo Clinic, so this is the 3rd edition, a few years later, and in textbook of cardiovascular surgery as an editor. Now, he has mentored 54, at least 54 people. He has been the principal investigator or associate investigator or co-investigator in 50 studies, all very elaborated surgical type of studies, and he has been a very creative person in terms of technology, and he certainly has more than 900 papers in the literature. And it's interesting, he started by looking at the myocardium in terms of protecting the myocardium. He was a resident at that time, then moving to the metabolism of myocardium, then moving to the hemodynamics and volumes and so forth, and he gave a very nice talk this morning about it. And then he moved into valvular heart disease and hypertrophic cardiomyopathy, and so coronary artery disease and aorta. And when you look at his curriculum, he's really a creative person about new technologies, new approaches, and so forth. So it is a pleasure to have you here, Harshal, today, and to share with us the whole day, and certainly this controversial issue that we'll have in a few minutes. And let me give you a plaque that says an appreciation for all of us and for outstanding teaching, wisdom, and expertise as the Anandi Sharma Visiting Professor and the Simon Dack Memorial Lecture. I was told that the check is in the mail.
Thank you very much, Val. It's an honor to be here. Thank you.
Yeah, thank you.
That's fine. Just stay in the light there.
I'm gonna hold it.
Good.
All right, thank you.
You can sit in the middle, I guess. And then we have so many experts today. So Laurie, you're here, Laurie Croft. Dr. Kinney is here. And then Amy, are you here? Mancini, Dr. Donna Mancini, Jose Miller, Paul Stelzer, Josh Lampert. Of course. There are enough chairs? Okay. Well, this is a difficult subject, and so much has evolved over the years in terms of detail, actually, that let's see how it goes. And we'll go from the beginning to the end, and that is to talk first about the epidemiology, about what disease are we talking about, and then we will move into the different entities and the procedures in therapies and so forth. Let's begin to talk about the epidemiology. Dr. Miller, we were told some time ago that 1 case out of 500 persons have hypertrophic cardiomyopathy. More recently, with the advances in diagnosis, we are told that it's 1 in 200. And I just was reading the other night that now it appears it is 1 in 100. So basically, I suspect that what we are talking about, we are identifying the disease more and more by the technological advances, I guess, and by the surveillance of people. So I'd like you to comment on.
It's mainly because we find one case and then we go to all the relatives and we start finding that asymptomatic hypertrophic heart disease is extremely common. And the truth is we don't have too much, we're not too sure what to do with the information very often, but those are the patients that we will follow. And nowadays, even if you find no hypertrophy, we are obliging somebody with a family history to keep looking for the condition as it will develop. So we're finding it much more. Fortunately, the prognosis is quite good. So we don't do too much to the asymptomatic person when we find it, but we are following them much more frequently.
So there are many more asymptomatic people that we identify just by doing the test. Amy, better you wake up here, because there's a lot of controversy about the genetics of this disease, and I have about 5 to 6 points that I would like to discuss with you. First of all, we call this an autosomal dominant disease, with about 11 or more genes being involved and about 2,000 sarcomere mutations being identified. But the question is, we are dealing with 1/3 of these people have mutations in the hypertrophic cardiomyopathy field, but where are the others? And we have to get into this, because now it's being questioned that the disease is just an autosomal dominant, which may be 1/3 only. And I'd like you to comment on.
I think that's fair, not only because of what you're saying about probands being found to have no genetic mutations in about 2/3 of the cases, but also because when you track a family, like what Dr. Meller was saying, you sometimes will find that the genotype-phenotype associations don't always match up. And it suggests there may be oligogenic or polygenic factors that play into the etiology of the disease. The other comment to make is that the genes that are being implicated are evolving over time. So I think we haven't discovered all the genes, and maybe some of the ones we were attributing to this disease were inappropriate.
It's interesting now, a few years ago, I still remember people saying that you could predict sudden death by one of these genes being mutated. Today, the prognostic implications of genes are close to zero. Is not correct? Okay. Now I'd like to ask about the surveilling of families, of people who actually have this problem. And I'd like you to ask a few questions. First of all, if you have a gene that is mutated in a patient with hypertrophic cardiomyopathy, and you go into a family and you check the same gene, and if it is negative, I think it's unlikely to inherit the disease. Is this correct?
I think it was previously sufficient to stop doing surveillance in those relatives, but in some cases, it doesn't always match up. So I think a baseline echocardiogram is appropriate for all of the first-degree relatives of someone with hypertrophic cardiomyopathy, whether or not you know their genotype. And once you've determined that their genotype is negative, you can stop there. But I would still do a baseline, because in some cases, you may be on the wrong track with the genetic discovery in the proband.
It is also interesting that many carriers will never develop the disease, but they can transmit the disease to the next generation. So it's pretty complex, the situation, isn't it, in terms of predicting the diffusion of the disease in terms of families. The other question is, I hear about a gene being discovered at least one every year. Is this because new technology of genetics, or what do you think is happening?
I just interpret those findings cautiously until they've been validated in multiple families. Because looking back, these large panels have been recurated, and the NIH has an action network called ClinGen, where they reappraise all the evidence for genes related to different genetic disorders. And they recently did this reappraisal for hypertrophic cardiomyopathy, and only 31% of the genes, or the mutations that have been linked with HCM are really, truly supported by evidence. So it's important not to jump to a conclusion just because one gene has been identified in one family. It needs to be supported by the finding in multiple families. Okay,
going back to the question being raised, actually, by Dr. Maron very recently. He's now talking about a disease that may not be genetic, and he mentions the different types of structure of the disease in itself that we will be discussing in a moment. In some, the leaflet is long. In others, it's a fibrotic process. In others, the chordic tendinae are abnormal. And he points out that this in itself is difficult to say that this is related to a gene or genes, because it's the variety of the disease they are talking about. And then comes the issue, and that is, let's assume that I have hypertrophic cardiomyopathy. my genes are all negative, then what I do with my children. And what is pointed out is, up until recently, you check echo every 2-3 years until age 25, but it can appear at age 52. Is this correct?
Yes, and I think the most recent guidelines from ACMG and Heart Failure Society of America support ongoing surveillance in adults indefinitely for family members of individuals with hypertrophic cardiomyopathy.
Okay, maybe we will come back to the genetic aspects when we talk about how to identify the people. But I would like to move now into the morphologic features by actually technologies of imaging. Laurie, you know, echo is great, but MRI has provided a lot of new information. So give us your feeling about these technologies. In fact, we are talking about these two technologies, basically.
So I think screening echo is imperative, as we said, and with our technology, echo actually, is portable and able to go wherever we need to go. With the use of contrast echo, we're able to identify the wall thickness more accurately. We're able to identify apical aneurysms more accurately. With up-and-coming strain, there's a lot of literature pointing now that maybe regional and global strain is actually more sensitive and more of a predictor of myocyte fibrosis than MRI and can predict it earlier on, though there are no outcome literature looking at that. As for MRI, late gadolinium enhancement of greater than 15%, as was pointed out by Josh, is a marker for sudden death. So between global strain, which is also associated with a higher risk of sudden death and from echo, and with myocardial fibrosis from MRI, we're able to see many markers that will help us risk stratify these patients.
Okay, so let me discuss with you actually the different ways that the disease it presents, okay? Usually we talk about thickness of the left ventricle should be about 15 millimeters or more. The problem is somebody may carry the gene or may develop this later, and you don't know what is going on at age 20. But let me tell you the types of ventricles. It can be a diffuse type of hypertrophy of the septum, can be focal. The right ventricle may be involved, maybe elongation of the mitral leaflet. And then on top of these, there are congenital anomalies of the insertion of the papillary muscle directly into the mitral valve, mid-ventricular muscular obstruction with the issue of apical cardiomyopathy or apical aneurysm. So what is going on here?
So, as you said, hypertrophic cardiomyopathy can present in many ways. The most common ones we see are the increased septal thickness that are usually associated with anterior motion, systolic anterior motion of the mitral valve with these elongated leaflets. But we can see aberrant papillary muscles that can cause obstruction. We can see bifid papillary muscles or any type of mitral valve apparatus that's abnormal. In some of the older patients, we see that basal septal hypertrophy without a reason, or sometimes in patients will have hypertension. And then sometimes we have to worry about the athlete's heart versus just a patient that has hypertrophic cardiomyopathy. So as you said, 15 millimeters seems to be that magic number. In an athletic heart, you can see 12, 13 millimeter hypertrophy, but usually it's associated with left ventricular dilatation or some other markers. So, and when they stop, exercising the LVH will regress. So I think you have to have good imagers that are looking for this disease and looking all over the ventricle for these abnormal areas of hypertrophy.
Is here where MRI is really making a significant contribution, and also in terms of fibrosis, more than 15% of the muscle with fibrosis may be in terms of a variable of sudden death, as we will be discussing in a moment. And then you can see the disarray in the septum today with MRI in a number of features which are actually fascinating. Well, I guess one of the aspects that maybe I would like to ask Josh about it is why, when you look at the literature, the obstructive disease is 70% versus the non-obstructive cardiomyopathy is 30%, and in just a registry for NIH, it comes 20% is obstructive and 80% is non. I'm just asking what is happening here. Is because the referral systems are different? Or just what is your feeling?
So I think that there are multiple aspects to answer that question. I think Echo as a modality in and of itself, which is where a lot of these patients are identified, as a very operator-dependent imaging modality. You need a tech who's going to be scanning, or in some cases an attending who's going to be helping scanning, and then the interpretation. As we also highlighted, hypertrophic cardiomyopathy is a very heterogeneous disease, and there are differences in ages when patients may present, may be identified, and there are also maybe even differences in gender. On average, women are diagnosed 6 years later than men. Is that a diagnostic bias, or is there age-related differences in penetrance?
Yeah. One of the main reasons is it appears that the obstructive type is the symptomatic hypertrophic cardiomyopathy, and the other is mainly asymptomatic, and that is these are patients who present in specialized institutions where they do this job and intervention and so forth, maybe one of the reasons. Well, Dr. Kinney, I have a question for you. You deal constantly with coronary artery disease, and you know, this is a disease that tends to be progressive. Okay, you get one event after the other. But it seems hypertrophic cardiomyopathy is not progressive. In fact, the disease appears to be the same. From time to time, you may have an event like sudden death, but it's not because the hypertrophy, once the disease is developed, is going to continue. So it's not peculiar, because it's one of the diseases in the cardiovascular field that we cannot talk about progression, unless you talk only at the beginning of the disease, but not when the disease is developed.
Even, I mean, that's an interesting question, but we see that many of the patients who are referred could be that they don't have a gradient, though there is hypertrophy. But I think with the age, when they develop diastolic dysfunction, for whatever reason, they'll develop some gradient across, and that's when the gradient develops and they become more symptomatic, whether it be any kind of arrhythmia or syncope, the way they present, and that's when I think we should consider treatment.
Okay, Dr. Schaff, we are getting slowly into you, very, very slowly. Now, let me ask you a question. So, you operate all of these patients, and my question is, what do you try to achieve? I can tell you 3 things. One is you may decrease mortality by whatever you decide to do, and we will go into the details of these. The other is you might want to have the patient free of symptoms in the obstructive type. And the other, you may perhaps prevent some comorbidities that may happen as a consequence of this obstructive cardiomyopathy. So what do you have in mind? Patients come to you and you operate, but what do you try to achieve there?
Well, to be clear, Valentin, I would say that 99 patients out of 100 are operated on because of limiting symptoms. Now, there is a consideration of improving long-term survival, and we can get into that in a discussion of reducing the risk of sudden cardiac death, but that's a consideration. But that rarely drives the decision for surgery or any other form of septal reduction therapy.
Okay, so in terms of sudden death, do you think that in an obstructive patient with significant obstruction, by doing a myomectomy, you prevent sudden death, or you may consider preventing sudden death?
Well, I do, and I'll give you the evidence for that. Now, first of all, everyone should remember, although outflow tract obstruction is not included as a risk factor for sudden cardiac death in the AHA-ACC guidelines, it is in the European guidelines. And if you look at all the risk factors for sudden cardiac death, there's really only one that you can change if you believe that obstruction is a risk factor, and that's outflow tract obstruction. Now, there's controversy about that, but the studies that we've done of our patients, both the surgical patients in terms of survival and the surgical patients in terms of ICD discharges, the risk of sudden cardiac death in ICD discharges is much lower in surgical patients than patients who are unoperated. Now, I'm open to arguments that doesn't hold, but that is in the back of our minds when we're speaking with patients and families about proceeding with septal reduction therapy for relief of symptoms.
Okay, so before we go into the structural procedures that you, with myomectomy, alcohol ablation, and so forth, I'd like to get into the issue of sudden death. Why? Because everybody talking about hypertrophic cardiomyopathy, the real fear is sudden death. That's the bottom line of what we are worried about. And in this regard, I would like to touch into three completely different aspects that address sudden death. Now, the first one that I want to talk about is the approach by the American College of Cardiology and American Heart Association, which is looking at the risk factors that may lead to this problem of sudden death. And you know, there are 7 risk factors that they look at, you know, family history of sudden death in first-degree relatives. They are looking at recurrent ventricular tachycardia. They are looking at the hypertrophy of the left ventricle, you know, when it reaches aspects like 30 millimeters. The issue of unexplained syncope, the issue of gadolinium with MRI of more than 15%, very interesting, and then the transformation into systolic dysfunction of a patient who has hypertrophic cardiomyopathy in actually apical aneurysm. 7 factors. What is interesting about this approach by the American Heart Association, which came in 2017, is that indeed, if you people who die suddenly, 95% have one at least of these 7 risk factors. But then we have the European score, and the European score is a summation. It tells you the possibility of a number of factors. So if you have 1, 2, 3, 4, 5, 6, the possibility that or the percentage of chance that you have for sudden death. The first method is very highly sensitive, which is the one in the United States. The European is very highly specific. And I just like to ask maybe you, Josh, again, into these 2 different strategies. The Americans really have criticized tremendously the Europeans, and the Europeans have not said too much about the Americans. Now, which one do you think is the most appropriate to follow? One is highly sensitive, and the other is highly specific.
So I think, as with every decision...
You prefer sensitivity or specificity? This is the bottom line.
So for this one, I would go with what's more sensitive, as the whole point of risk stratification is to identify patients who are at a risk for sudden cardiac death. And then I would take steps after that to risk stratify and decide who we should actually put the ICD in. And there are different components to that decision, such as the patient's age, if they're going to have a transvenous or subcutaneous device. Also, you know, for example, an ICD lead will fail at a rate of 1% per year, inappropriate shocks. So it depends on patient's age and what their underlying risk is. But I think starting with what's most sensitive is what makes most sense to me. Okay, it makes a lot of sense. Well, then the NIH just came up about 3 months ago with a new approach, which is we can do better than the American score system and the European score system. And what they did is they had a registry of actually 3,000 patients with hypertrophic cardiomyopathy that were recruited from 44 sites in 6 countries. And this has been done over the last few years. I think it has been done over the last 7 years. And what they look at are 3 issues. One is magnetic resonance imaging, as we mentioned with Laurie before, to look at the fibrotic phenomena and to the interstitial fibrosis particularly. The other is biomarkers, and they began to measure troponin and then NT-proBNP, and then a genetic analysis. And they begin to look at, and thus far there are no results of what is the best approach, but they have 2 completely different settings when you use the 3 variables. The first setting, actually, if you have a positive genetic profile, that is one of the genes that we talked with Amy, that is positive, these patients actually tend to be younger, and they have the non-obstructive type of cardiomyopathy. This is one thing they have, and are very fibrotic. So you have the 3 technologies with a very specific group of people. On the other hand, a large number of patients, highest proportion, they are negative in terms of the genetics,
And these particular patients, they don't have fibrotic phenomena, or very little, and then they have significant obstruction. And they're following, these two groups are completely diverse, and they don't have any idea which one of these groups is going to be having more significant from the prognostic point of view and in terms of outcomes. The only thing I'm saying to you is that the field is rather difficult, but at least everybody's trying to do the best for the prediction of sudden death. And here comes the question. If you look at all the therapies that have prevented sudden death in patients with hypertrophic cardiomyopathy, actually one by far is the defibrillator. Dr. Mancini, what do you think about that? Because we are going to be talking in a moment about heart failure, but I'd like you to, you now are an expert in arrhythmias, and I'd like to know what you say, because of all the procedures, really by far has been the most important one is exactly the issue of the defibrillators. And most importantly, you can have shocks, and this doesn't make the natural history worse later on. So I'd like your comment.
You know, in terms of the prevention of sudden death, I generally will look at certain key variables. I do think that the MRI and the degree of fibrosis is a very good predictor. And if there's a lot of fibrosis, I tend to favor placing the device. Clearly, if there's a history of sudden death in the family, place the device. And if there's really marked hypertrophy, I also am concerned about the risk of sudden death.
Well, I can give you figures which are very consistent from all these studies. If you decide to put a defibrillator for primary prevention following one of the scores that we mentioned, whether you follow the American or the European, the chances of having a shock is 4% per year. If you use it for secondary prevention, the chances are 10% per year. That is the issue. Now, in terms of complications of the device or firing in the wrong time, is about 5% per year. So this is very interesting. And it is you put the defibrillator, and certainly is the most important preventive strategy for hypertrophic cardiomyopathy. On the other hand, the possibility of complications is not trivial. And this leads to the issue of using subcutaneous defibrillators. And I'd like anybody of you to comment about whether you have experience in using the subcutaneous defibrillation in patients with hypertrophic cardiomyopathy. Any of you have experience? Yes, Amy.
We've recommended a few patients through our program for ICDs, that young individuals who were averse to having a wired ICD, and in discussion with the EP, had opted for a subcutaneous device, and they've done well anecdotally.
Okay. Well, let's now move into something that is somewhat far from sudden death, but is in making the patient to feel better. And let's now address the issues of how we treat hypertrophic cardiomyopathy, the obstructive one, and how we treat the non-obstructive hypertrophic cardiomyopathy. I don't want to go into too much detail, but perhaps is of interest that the data about the use of beta blockers, for example, or even calcium blockers, and even the use of Norpace as a negative inotrope, the results are very variable and cannot be anticipated. And this is across the literature. I'm saying because those of us who have been in the medical field, we always think that the patient is symptomatic, we're going to give beta blockers and the whole thing is going to work well. It doesn't appear to be the case. Jose, what is your experience just with the use of medical agents in hypertrophic cardiomyopathy?
I think that there is like a 50-50% chance that we'll get better with less symptomatic with a beta blocker, and the ones who don't tolerate it end up with the calcium blockers, reserving the Norpace for the failure of those two, or adding it to, but especially for non-older men who will not tolerate it because of the prostatism that they will have. But I would say it's a 50-50. That's why eventually some of those patients end up for symptoms now with the two other approaches to reduce the outflow.
Okay, Dr. Schaff. you are one of the fathers of myectomy, and it seems to me it's more of a complex procedure than what I expected to. First of all, is the ideal approach in patients who have hypertrophic obstructive cardiomyopathy. But I'd like to ask you a question, and I have your data here. One is to do the myectomy alone, and the other is to do the myectomy plus doing something to the mitral valve. And your results on the first approach are good. The results on the second approach are quite questionable. I'd like you to comment on. Actually, I will just to say that the mortality at the Mayo Clinic for myectomy is 0.4%.
Well, the debate among surgeons about whether you need to do something to mitral valve, I think has been settled if you're talking about replacement versus repair versus myectomy alone. The issue of whether you need to manipulate the mitral valve to relieve outflow tract obstruction is still open, but our philosophy is that you should not do anything to the mitral valve until you've relieved SAM. So if you do an adequate myectomy, you come off bypass and see if there's any residual SAM and mitral regurgitation. Because the only patients that we would do something to the mitral valve for are patients that have intrinsic mitral valve disease. There are a number of patients that have ruptured cords or some intrinsic mitral valve disease, and we would repair the valve at the time of myectomy. But it's not necessary to do a mitral valve procedure to relieve outflow tract obstruction other than relieving an anomalous papillary muscle that inserts into the anterior leaflet.
The next question for you is the same we learned from the group, Adams and others, on the mitral valve repair. The risk of operative death is increased by a factor of 12 when myectomy is performed in centers with a lower volume of such cases. So the issue of volume comes again with this surgical procedure.
Well, this is a sensitive issue because it's a relatively simple procedure that's difficult to teach. And the reason that it's difficult to teach is because the exposure is quite limited. And so the best view of a septal myectomy is on a video. It's not standing at the operating table and watching it. The surgeons who have probably a better introduction to this are congenital surgeons who have been operating on subaortic membranes and are familiar with the subaortic area, but it's just not a procedure that's commonly done. There's no question that the results are better. It's one of the procedures where the more you do, the better you get at it. And we've thought long and hard about ways to shorten the learning curve. I can't tell you exactly what the learning curve is, although we're investigating that now, looking at number of cases versus gradient reduction in a large group of patients. But I think what you've said, Val, is absolutely true, and it's something that we need to wrestle with as surgeons in order to teach this better.
Well, there is a problem. In fact, we will discuss in a moment alcohol ablation, but before I get into that, it seems that the institutions that they have a high volume of hypertrophic cardiomyopathy are not significant numbers, and not the surgeons either. So the alcohol approach has evolved across the board in many institutions that really not necessarily have a high volume of IHSS, but because the patients cannot have a myectomy in the specialized centers. This is something that is coming out in the literature and is of great concern. What do you think? We'll talk about alcohol ablation in a moment, but what I'm saying is like the backup when there are not enough institutions to do myectomy.
Well, I think the posture ought to be that the patient gets the best advice regarding for or against septal reduction therapy, and then best advice on which septal reduction therapy would be best for that patient. And I think in most instances that advice is best given in a comprehensive center, a center where you have cardiologists and geneticists and echocardiographers who are familiar with the disease and can give that balance. I'm not sure that because you don't have surgery, that's a reason just to do alcohol septal ablation. I think if it's your recommendation that the patient have surgery, then they ought to be made aware of that.
Okay, I'd like to ask another question to you. Josh mentioned in his manuscript and is everywhere, the myectomy really works wonders. The symptoms go away in 90% of people. The gradient gets close to zero. There is no recurrence. And I think these are important facts. Are you impressed with your results in this regard? I mean, you have followed these patients.
Modesty
I'm not talking about
prevents me from
mortality.
answering.
I'm talking about really quality of life and hemodynamic results and symptomatology.
Listen, I told someone once that doing a myectomy for a symptomatic patient with hypertrophic cardiomyopathy is like doing a bypass operation on somebody with unstable angina. They have terrible disability one day, and then the day after surgery, they have no angina. It really cures the symptoms. It doesn't mean you don't have hypertrophic cardiomyopathy. It doesn't mean you don't need to be followed and assessed for risk of sudden cardiac death, et cetera, et cetera. But it is very dramatic as regards to relief of symptoms. And so the short answer is yes.
Thank you. Okay, Dr. Keeney, let's talk for a moment about alcohol ablation. Actually, the results, there are many studies. These are actually a meta-analysis done of 14 different studies recently, but I'd just like to summarize, and that is, the results are very good in general. Not as good, the mortality, when you look at all the data, is slightly higher than in patients who have the myectomy. The results in terms of the gradient, you don't get a gradient of zero, okay? So that is a little bit negative. And the other aspect that is perhaps negative is the recurrence of having to do another alcohol ablation is 10 to 12%. On the other hand, it's easy to have a patient just non-invasively, patients like it, and so forth. But there is a warning, and this comes from the European Society and from the American Society, very recent warning, should not be done in people under the age of 40. And the reason for that is because that one doesn't know the long follow-up and knowing that myectomy is so good, rather than doing this in young people, they try to perhaps get away. I'd like you to comment in all these aspects.
So myectomy definitely has a very long follow-up and good results in the best centers and best hands. And who are the patients should be referred to? Myectomy are, like you mentioned, who are younger patients who have a thick septum, usually is more than 3 centimeter, with or without mitral pathology. Now, the type of cases that are referred to us to the cath lab are older patients, whether it is a typical genetic hypertrophic cardiomyopathy, or is it hypertrophic cardiomyopathy that has been diagnosed at a later age or due to hypertension, who have multiple comorbidities and who probably not candidate for myectomies. So like Dr. Mello mentioned, they have to be on medications. Usually is a beta blocker plus minus calcium blocker. Most of us and the patients do not like to be on Norpace. So usually when their symptoms still persist on the medication, they are referred to us. And the diagnosis is always made with by the echocardiographer. So what the guideline says and what we do also is the same, that they may not have some baseline gradient, but provocable gradient above 50, and if they have symptoms, those patients, when they do an angiogram, we always see if there is a septal that we think we can ablate by giving alcohol. So this is a team effort, which usually myself and Lori do it together. We need an echocardiographer in the room so that as we are doing the angiogram, and then we select the septal. Once we go to the particular septal, we will inject the definity and then define a very small part of the septum, which we think is the one that we are going to ablate. And actually, if you think about it, the gradient disappearance is instantaneous. That you'll see a difference in the gradient. We almost bring it down to less than 30 when we know we want to be successful. And slow injection of alcohol, not more than 1 to 2 cc's weight, so that slow injection is the key, so that one of the biggest side effect for this alcohol septal ablation is the need for pacemaker could be up to 10%, is something that we want to avoid, and that we do by injecting alcohol cautiously. So I think I have said that it has to be done in elderly patients who are not a candidate for a myectomy.
Thanks for mentioning the pacemaker aspect, which is 10%.
Yes.
About it. Let's talk about for a moment about left ventricular apical aneurysm that we said could be one of the risk factors that, for sudden death. Well, in fact, when you look at the figures in the original paper from Maron and others, the figures are that only 5% of the hypertrophic cardiomyopathy patients have an apical aneurysm. In the pathophysiology, well, first of all, is 5%. From these 5%, when you take overall apical aneurysms, only 3% of them have sudden death. So maybe we went too far in making this like a big issue when you really look at the figures. Having said this, the mechanism is interesting, and this has been outlined by a number of technologies. It seems that there is a mid-ventricular obstruction which creates a hemodynamic burden at the apex, and this creates actually ischemia in the microvasculature with fibrosis, and this could be leading to the sudden death. There's a lot of data done with magnetic resonance imaging. And what is fascinating is this is completely missed, the mid-left ventricular obstruction, because when you look at echo Doppler, the velocity actually is not increased, it's obstructed. And it's very fascinating that people can miss the obstruction when in fact the surgeons could be quite helpful in that regard. So I'd like just to, a little bit of a comment, and Dr. Schaff, I have the following question. Most of the myectomies are done transaortic, is this correct? And the other, I would ask, this apical probably is transapical, I'm just asking you.
Right. For subaortic obstruction, we will almost always go through the aorta. For mid-ventricular obstruction, we prefer to go through the apex, and certainly for an apical aneurysm or pouch, we would do an apical ventriculotomy. But it's very important to get rid of the mid-ventricular obstruction at the time you repair the aneurysm.
Okay. Ahim, I'd like to discuss before we go into the non-obstructive, I'd like to ask maybe again to you, there are new approaches that I'm very interested in you to comment on. Percutaneous mitral valve plication as a primary therapy for symptomatic obstructive hypertrophic cardiomyopathy. In fact, there are 6 cases published very, very recently from Minneapolis, from Maron's group. Do you have any experience on clipping the mitral valve in a patient like that?
No, we've not done that. I'm aware of the paper, and I think for the elderly inoperable patient, it might be something to try, but I don't, my bet is it won't become mainstream.
The other approach just came up from China, which is intramyocardial septal radiofrequency ablation. It's like laser technology, and they provide interesting results in about 30 patients that they did with a good follow-up at 6 months. Are we getting now interventionally with these kind of procedures? Dr. Kinney, maybe you have a comment about it. Did you hear about this?
Yes, we have heard about that, and other technique that has been reported in the past is that you can get rid of the septal artery by putting a cover stent in the LAD. That's another technique that has been reported also that it could be done for these patients. But the issue with getting rid of the septum is the same. One thing I forgot to mention, we got to be why the technique we do has to be done with the finesse and go to very small branch of the septal, so that the myocardial infarction that we have caused should be very little. We don't want to see a CKMB greater than 1,000 in this patient. So you really want to cause a very small myocardial infarction in this patient, because there is also this literature that once you cause myocardial infarction, a little bit of scar, which could subsequently give rise to more arrhythmia. That has been reported also. So that's very important that when we are doing the septal ablation, we've got to be very cautious that you cause myocardial infarction, but to a very small territory.
Thank you. Donna, I want to now touch into the non-obstructive cardiomyopathy. As we said at the beginning, the proportion of non-obstructive versus obstructive cardiomyopathy, hypertrophic cardiomyopathy, it changes from paper to paper. At least the summary that I got is if you go into specialized institutions and the patients get there, in general, the symptomatic patients with obstructive cardiomyopathy, and this is about 70%. However, in the registry from NIH and in other widespread institutions across the world with hypertrophic cardiomyopathy is much more predominant, the non-obstructive type, which tells us that you may identify by echo an asymptomatic patient, as discussed previously, and this goes to any institution, while the institutions which have expertise, it goes to obstructive. What is your experience about this? I have a few questions for you about this particular entity.
My experience with hypertrophic cardiomyopathies are usually the people who have failed everything, who have failed medical therapy, who have failed if they have obstruction, surgical or ablative therapy. So I usually see patients that are burnt out, and I do see quite a lot of end-stage hypertrophic cardiomyopathy that have terrible heart failure and reduced ejection fractions and are in the dilated stage. I've never sent anyone for alcohol ablation. I've always preferred to do myectomy over alcohol because I think it's not as good a technique. But usually by the time I see the patients, they're exhausted. Once they come to me and they're in end-stage heart failure, we put them on a transplant list, and patients who have hypertrophic cardiomyopathy and get transplanted do extremely well post-transplant.
Well, let me ask you a few questions here, because the literature says something that is interesting. I thought this was like heart failure with preserved ejection fraction, but in fact, 90% of these patients are asymptomatic. So we are dealing with a population that, contrary to what you might think, in fact appears to be mainly asymptomatic. The problem is that 10% end up with systolic dysfunction, and then you are in big trouble. Now, the question here is how you manage these patients. From the NIH registry, these are the patients who, in fact, are genetically positive. They have a significant longitudinal aspect of the septum, very thick. And these are patients who have significant fibrotic myocardium. To me, this is the same that you see in heart failure and preserved ejection fraction, is not?
Not necessarily, no. Because the patients with preserved ejection fraction, generally they don't have the asymmetric hypertrophy and they don't have the problems with obstruction that the hypertrophs have.
Okay. So, the answer is transplantation. There are a number of patients have been done, and I don't know if we have any experience. Dr. Schaff, do you have experience in terms of transplantation in this type of population, those 10% that really get into trouble?
We've done them at our institution. I don't do the cardiac transplants at Mayo. The patients with non-obstructive hypertrophic cardiomyopathy, and perhaps you were going to get to that later, that are candidates for surgery are patients with small left ventricular volumes, patients with a crowded ventricle in whom chamber compliance is decreased because of the mass of the muscle inside. And in those patients, most of them are phenotypically apical hypertrophic cardiomyopathy. And in those patients can be helped with an apical myectomy to enlarge the ventricle. So that's the main procedure that I would do for non-obstructive disease.
Okay. Another question, since you have when we see these patients with this kind of Japanese apical hypertrophy, do you operate at those? Because there is some data that even it's like you don't have obstruction, but still you do a myectomy. I just like to ask your opinion.
No, most patients with apical hypertrophic cardiomyopathy will be asymptomatic. But when the patients become symptomatic, they're very difficult to manage. They don't respond to beta blockers, they have diastolic heart failure, and they're very troublesome. So the only alternative, other than this procedure that I just described, is cardiac transplantation. Now, there's two groups of patients that we think benefit. One would be the patients with the typical phenotype of apical hypertrophic cardiomyopathy, where the whole distal half of the ventricle is obliterated by cardiac muscle. And a second group that we've found more recently in the last 5 years or so that have benefited from surgery are patients that have small ventricles that during systole completely obliterate during systole. You see an ejection fraction of 80% or 85%. And those patients are limited because when they exercise, they can't increase their stroke volume at all during exercise. And if the patient has that anatomy and symptoms of heart failure, clear diastolic heart failure, then we would consider them for an apical enlargement procedure or a transapical left ventricular enlargement procedure.
Thank you. Paul, you heard all sorts of things this afternoon about the procedures that being done, particularly in the obstructive cardiomyopathy. What issues you think you have been thinking about that were interesting, or something that you would like to add to what you heard?
Thank you. Well, it's a pleasure to have Dr. Schaff here to talk about this experience, because that apical myectomy is something that is not for the beginners, that's for sure. The trans-aortic valve ones, they're much more common. And I think he hit on a good point that it is a difficult operation to teach, and that the congenital fellows are a little more aware of the anatomy involved. And part of it is like Paul Damas commented to me some years ago, is that the difference between us and this average adult heart surgeon is that we think in 3 dimensions. And the pediatric guys have to think that way to put these crazy hearts back together that get curveballs from Mother Nature. Same way here. When you think about septal myectomy, you can't just have your knife perpendicular to the floor, because that's not the way the septum is running. But when I've been on both sides of the septum in so many cases with my Ross work, I know exactly where that septum's going. And so it's a lot easier to direct the blade when you know what's happening on both sides of the septum. And it's also important to get deep enough and wide enough to make a really good relief of the obstruction. There are some anomalous connections that have to be released. And those can't be treated with alcohol. They're very difficult to image, I think. We can see whether Lori's got some magic up her sleeve that she can find them now. But if you spot those, you want to release those connections, especially between the papillary muscle and the anterior septum. Divide those two all the way down to the base of the septal muscle, and get that looking really, really good. That's if you don't go deep enough, you're going to leave the very point where the obstruction starts, where the anterior leaflet catches on the septum. And if you came down to that point but didn't go far enough, you're not going to get the problem solved. So it takes a little bit of courage to go down far enough to do that. But if you don't do that, it's not going to work. Atrial fibrillation is also something to be avoided in these patients, and that's something that really tips them over.
Okay, let me finish, Donna, with Donna Mancini. Don't worry. Look, atrial fibrillation, there are many paradoxes here, many paradoxes. First of all, the incidence is low in a cardiomyopathy that tends to dilate the atrium, and this is 20%. And actually, this is paroxysmal atrial fibrillation leading to a permanent atrial fibrillation only in 25% of the patients. What is interesting, and there is a literature about this, that what you would expect, and we all talk about in rounds, a patient with hypertrophic cardiomyopathy and atrial fibrillation is big trouble. You are not filling the ventricle and the patient does poorly. It's not the case. And in fact, one of the reasons may be that the ventricle gets more dilated with atrial fibrillation, and in fact, you decrease the obstruction. This is one of the theories. But what is fascinating, and I would like you to actually give us your comment, is again, in contrast with patients with heart failure and preserved ejection fraction, we have an entity here, as you said, that is different, but also in the way it acts with atrial fibrillation. I'd like your comment about it.
Most of the patients with hypertrophic cardiomyopathy that I've seen that have gone into atrial fibrillation have had acute deterioration and have not really had an adaptation of the ventricle with dilatation from the atrial fibrillation. So I don't have an experience where that's not the case.
Okay, so I'm going to finish by making 8 statements, and I would like which one each of you feel that is the most exciting one, all right? I begin. The mortality rate today with myectomy in good hands is 0.5%, with most of the symptomatology being abolished. Point number 2. The defibrillators, implanted defibrillators, is in about 10% of patients. And this is the main, by far, the main therapeutic approach for the prevention of sudden death. Third, hypertrophic cardiomyopathy is not a progressive disease. It's a disease that stays the same, but can be an event from time to time. Fourth, without specialized centers, multidisciplinary centers, we are not approaching this disease appropriately. Number 5, the disease is now recognized worldwide, and it appears to be the same here, in Africa, in Asia, everywhere. We didn't mention about that. The other statement is about women. As usual, women are detected late, have not been treated properly, but actually the outcomes in women are exactly the same than in men in this disease. The modern technologies that Laurie was talking about, MRI has been one of the most exciting and striking advances in the understanding of the disease, and also from the prognostic point of view. And then from the therapeutic armamentarium, aside of the defibrillators that may prevent sudden death, the 3 following therapies that one might consider that may decrease death, sudden death, surgical myectomy in patients with significant obstructive cardiomyopathy, heart transplantation for patients with end-stage non-obstructive cardiomyopathy, and something we didn't mention is the use of anticoagulation in patients with atrial fibrillation. And the final comment I'd like to, at least you to comment about, is that adverse cardiovascular events and death levels are below the levels among patients with other cardiac or non-cardiac disorders. So I'd like to go one by one. You only have 15 seconds. And which of these statements or other statements really are most surprising to you, or more exciting, or more positive? Dr. Mella.
I'm not too excited about the women's stuff, but the ICD, I would think is the most important decision that we have with these patients. And as you said, 10% of them end up with it.
Yeah, I agree. I would say the same thing, the defibrillator. Dr. Kinney.
Number 4, where it is a multidisciplinary. I think these patients are complex and they have to be referred to some specialized center by the group of physicians who will make a combined decision what is the best treatment for a given patient. And I would like to add, septal ablation is a treatment that can be given to this group of patients.
Dr. Schaff?
Well, I'm going to vote for number 1, but I get to explain. And the explanation is we're very bullish on ICDs, and the importance of that in preventing sudden cardiac death can't be underemphasized. But if you look at the number of symptomatic patients 70% will have obstruction, and the number of patients you help with an adequate septal reduction therapy is much, much higher than the number of patients who will eventually benefit from a defibrillator. Now, I understand the difference between getting rid of dyspnea and sudden cardiac death, but the number of patients helped by septal reduction therapy is enormous.
Thank you. Amy?
If I may add something extra to the list, we didn't cover the novel emerging therapies for hypertrophic cardiomyopathy, the small molecules, mevacetine, which is a myosin allosteric inhibitor, and looks like it's doing a really good job of reducing obstruction in the symptomatic obstructive hypertrophic cardiomyopathy patients and may have a role even in non-obstructive.
Thank you. Paul?
I'll go with the mortality of 0.4 or 0.5%, is that the bar has been set. We need to seek
Thank you.
that quality.
Josh?
I think ICD therapy can be understated in choosing which patients should be appropriately getting them. But also I agree that the novel pharmacotherapy that's coming up is very important to consider.
Thank you. Laurie?
I would agree with ICD therapy, and I would echo what Dr. Schaff says about patients want symptomatic relief. So whether it's a myectomy or an alcohol septal ablation, that's very important. And a final note, I think a lot of work is going to be done with global strain to try to help identify these patients and help differentiate hypertrophic cardiomyopathy from hypertension.
Thank you. Donna?
I would say a multidisciplinary team is very important. And I have to say that at least the patients that I see, they seem to have progressive disease. You don't think they have progressive disease?
All right. No comment. Any question?
Place out of state, and when he came back, he was in heart failure, and the septum was very hypokinetic, and he did very well with Entresto, so he's fine now, and he's better than he was before. But my question is, when you chop out lots of amount of heart, and particularly in the apex, what happens to the muscle contraction after that?
Well, the operation works if you preserve contraction. It's clear that if you remove the muscle, you damage the surrounding muscle. It won't work. In our experience, when we've done hemodynamic studies and patients had the operation, the ejection fraction is preserved. But I accept the fact that if it's not preserved, you're in trouble.
You have a comment?
No, it's a question for Dr. Schaff. I was curious about that small ventricle hypertrophic, hyperkinetic ejection fraction over 80%, where you do apical enlargement. Wouldn't that apex become aneurysmal or even more?
Yeah, I apologize, Dr. Miller, I misspoke. We do a transapical myectomy, but it's not just at the apex, it's to enlarge the septum.
You go through there to really
Right.
remove muscle
To
everywhere.
remove muscle, but it's not just at the apex.
Okay, I see.
Well, if there's no other comment, thank you very much to everybody, particularly to all of you.